I'll I'll get started. So the learning objectives for today are to describe the contents of the hip fracture care implementation toolkit, including change ideas, resources, and tools. We'll then review the proposed quality improvement learning calendar for ECHO and how it supports implementation, and then wrap up with an introduction of the evidence to practice program and its alignment with the hip fracture quality standard. So as a bit of a background, we'll open with a brief overview of the 3-year provincial implementation strategy. We have presented previously, but in case there are people that haven't been at earlier sessions, we'll just give a brief overview and why we're focusing on hip fracture care now. Ontario Health updated the hip fracture quality standard in 2024 with new evidence in clinical practice guidelines. In addition to the quality standard, there's been a lot of work done in the past on hip fracture, including the Bone and Joint Canada Hip Fracture Toolkit published in 2011. Quality-based procedures were published in 2013, and the original hip fracture standard was published in 2017. But hip fracture needs to come back onto the radar as a priority for many hospitals with improvement potential. Data shows substantial variability in the quality of hip fracture care across regions and organizations, and there's still a lot of room for improvement. Supporting hospitals with data, tools, and training will promote quality and equity in surgical care for older adults. And focusing on priority clinical areas will target improvements to patient outcomes such as reduced mortality, time in hospital, and readmissions. We know substantial improvement is possible. We've seen it from a number of organizations that have prioritized quality improvement work. And one example is London Health Sciences Centre, which was spotlighted in a spotlight report that's posted on our website. We have some QR codes here, and we were going to put some links in the chat. I think our site is down unless something has changed. So if we don't put the links in now, we will follow up with Jenny and share all the links as well as the slide deck following today's session. So next slide. Again, hip fracture is a huge resource allocation for hospitals, given that it's a common injury, over 13,000 per year. It's also one of the most expensive admission diagnoses, with additional non-acute care costs during that first year. So from a system and demographic perspective, we also know that the numbers are not going down because of aging, and we need to get ahead of it in Ontario. So Ontario Health has started on an iterative journey, and here we've mapped out a 3-year roadmap for hip fracture improvement. We're just in our first year, so just getting started. We've been doing a lot of engagement and planning with early adopters and leaders in the emergency department and acute care areas. And we've really focused on confirming clinical priorities, establishing where there are provincial supports that align with this initiative and can support this work, building hospital awareness, and aligning with our system level goals. In year 2, we'll continue with implementation and coordination through launching and testing acute care change ideas, piloting and enabling digital tools like the Evidence to Practice program, which we'll hear more about today. We also plan to explore barriers to inter-hospital transfers and strengthen regional and system level coordination. And in year 3, we'll focus on spreading and scaling up the successes. So the next slide, it speaks to hip fracture areas of focus for quality improvement. 5 of the 15 hip fracture quality statements, which are highlighted in orange on this slide, have been prioritized as the first ones will target and share change ideas to galvanize system efforts. We've also noted quality statement 1 since it's highly aligned with emergency department management is highly aligned with quality statement 2, surgery within 48 hours. We recognize that regions and hospitals have a lot of priorities, and as we plan for year 1 activities, we are conscious of how this work aligns and can build on existing work underway. All of these areas contribute to core system and hospital priorities listed in the top of the slide in blue, to improve hospital flow, shorten length of stay and alternate level of care, and prevent unnecessary readmissions. So there's clear alignment between the hip fracture priorities and some of the overarching big OH regional clinical priorities. And so we're really trying to work and align with those and leverage existing tables and community of practices and any other levers that are available provincially. And the next slide highlights the many provincial supports and implementation levers that we're using to align our activities with. So today's session, we're going to focus on key supports to enable this work. And first, we'll introduce the newly developed Hip Fracture Care Implementation Toolkit. And then following that, in the next session, the Evidence to Practice team will showcase how it's aligned with the Hip Fracture Quality Standard and Toolkit. So I'll pass it over to Dana Summers to introduce the Hip Fracture Care Implementation Toolkit.
Thanks, Carol. Hi, everyone. I'm Dana Summers Laframboise. Next slide. Okay, so this is the Hip Fracture Care Implementation Toolkit, a cover of its photo. And this is a resource that is developed for clinicians, healthcare teams, and decision makers involved in hip fracture care. The purpose of this toolkit is to help healthcare teams implement the 5 priority quality statements from the Hip Fracture Quality Standard by appointing them to practical strategies and useful resources to address common barriers to providing high quality hip fracture care. Next slide. So to develop this toolkit, we recruited an advisory group of clinicians from across Ontario with extensive experience in hip fracture care and quality improvement efforts to improve hip fracture care, listed here. And so this group includes representation from orthopedics, geriatrics, emergency medicine, primary care, nursing, rehabilitation, physio and occupational therapy, social work, pharmacy, osteoporosis management, and it also includes academic and community hospitals. And some of the clinicians on this committee have been working to improve hip fracture for decades, and they have profound knowledge of the best practices as well as insights into Ontario's healthcare system and its unique challenges and constraints. Next slide. In addition to the advisory group, the other key inputs to the development of the toolkit include the Hip Fracture Quality Standard, clinical practice guidelines and literature on hip fracture quality improvement, and engagement with key audiences. We also reviewed the Ontario hip fracture data to prioritize 5 of the 15 quality statements for focus. And then we worked with our advisory group to select practical change strategies that they believe have the most potential to help hospitals make meaningful improvement on hip fracture care. And finally, resources that hospitals can leverage as they implement those strategies. Next slide. And so inside the toolkit, you will find your starting point in making hip fracture improvement. So you can compare your current practices against the 5 quality statements to identify gaps, and you can use existing data to prioritize where improvement is most needed, and then take action by accessing change strategies, resources, and real-world examples of effective interventions to recommended to you by our experts. And so next slide. At this time, I will ask our team to open the toolkit itself so we can take a look inside. Okay, so I'll flip through a few of these introductory slides quickly because we've covered most of this content during our introduction here today. Here's the cover of the toolkit. On the next slide, we have a table of contents with navigation links to help you click directly to the different parts of the toolkit. And the next slide is the introduction, which explains the purpose of the toolkit and includes links to other Ontario health resources, including the Hip Fracture Quality Standard, as well as, let's see here, where are we? Some implementation for a case for improvement for implementing change and sustaining change. Next slide. Okay, this slide explains why we created the toolkit and why we selected these 5 quality statements for prioritization based on their potential to improve patient outcomes and hospital performance indicators. Next slide. Here we have an infographic on the 15 quality statements. I don't know if that's just my computer that blanked out for a second there, but so we've got the 15 quality statements aligned to the patient journey. And with the 5 priority statements highlighted in the top portion. And then the next slide has briefly explains how to use the toolkit to focus on quality improvement efforts and select change strategies and resources. So that concludes the introduction. Now we'll move into the assess section. So here we've included resources that hospitals can use to assess the care that you're currently providing. So the first link is to the hip fracture quality standard, and we recommend that you start there to identify where your current practices may not align to the best available evidence. And you can use Ontario Health's action plan template to start thinking this through. Then we suggest that you look at Ontario Health's hip fracture e-report to review your organization's performance on key hip fracture indicators, such as mortality within 30 or 90 days, surgery within 24 to 48 hours, or alternative level of care, length of stay for hip fracture hospitalization. And there's about 8 or 9 indicators there. And information on how to access the hip fracture e-report is included on the right-hand side. Then on the next slide, we have also included links to other data sources, such as the Quality Improvement Plan program with the new indicator on hip fracture surgery wait time, and how hospitals that are participating in the Ontario Surgical Quality Improvement Network can collect targeted hip fracture through NSWIP. And then on the next slide, finally, we have included the statement-specific indicators. So these would be locally collected from the hip fracture quality standard for those who want to track their progress on making improvements on the 5 priority quality statements. So that's the end of the assess section. So now, without further ado, let's dive into the change strategies. So the first page of the change strategies includes links that take you directly to each of the change strategies for your convenience. And of note, I just want you to notice under screening for and managing delirium, which is quality statement 10, this is one of our priority quality statements. And through the Delirium Aware Safer Healthcare or DASH campaign, Ontario Health has already developed an implementation toolkit to help with its through the help of its own advisory group. And so to avoid reinventing the wheel, this toolkit links you directly to the DASH toolkit. The rest of the change ideas are grouped by the priority quality statement that they align to, and change strategies for weight bearing as tolerated and daily mobilization are combined because there is so much overlap among the change ideas for these 2 topics. And there's also a section of overarching strategies. So these are strategies that we think help improve care at multiple points along the care pathway. So the first change strategy on the next slide is identify local champions. This first overarching strategy reads, identify clinical leaders to take on the role of local champion to ensure accountability in the adoption of best practices and culture change. And we selected this change idea because, as we learned from our advisory group about their hip fracture quality improvement efforts, this simple idea came up again and again, including in the hip fracture spotlight report on London Health Sciences Centre. Change cannot happen without champions to lead it. And to that end, we've included several resources on this page about leading change, culture change, and building an effective multidisciplinary team for hip fracture care specifically that we hope you'll find useful. Next slide. The next strategy with potential to improve many aspects of hip fracture care is establishing an orthogeriatric model of care. And this change idea reads, establish an orthogeriatric model of care by improving clinician and interprofessional team training on care for older adults to improve care experience and reduce complications. So importantly, this strategy notes that orthogeriatric care can be provided by any clinician with training for on care for older adults. You don't need to have a geriatrician on your team to do orthogeriatric care. And a systematic review showed that orthogeriatric care reduces length of stay, in-hospital mortality, 1-year mortality, and the rate of delirium in people with hip fracture. And it also found that orthogeriatric models may reduce complications and costs. So to help you with this strategy, we've included an overview on the effects of orthogeriatric models in outcomes of hip fracture patients, and as well as a textbook chapter on establishing the orthogeriatric service, and then also recommend that people join the Project Echo community of practice. So for those of you who are here already, you can check that change strategy off of your list. And okay, so the third overarching strategy on the next page is provide tailored education to patients and care partners. And it reads, equip patients and families to be partners in care by providing them with multimodal education in multiple languages that addresses key aspects of hip fracture care, including screening for and preventing delirium, weight bearing as tolerated, daily mobilization, and bone health management. And so once again, as we spoke with hospitals that had made significant improvements in their hip fracture outcomes, we repeatedly heard that revamping their patient and family education materials was a key strategy. And so by providing educational materials in multiple formats, for example, booklets and videos, posters, and in multiple languages, these organizations were able to help more patients and families understand their role in optimizing recovery as the patient moved along the care pathway. And so in areas such as weight bearing and mobilization, patients and families might not understand why these are so important. And so getting them to on board and to partner with the care team can really make a difference on how the patient recovers. And we're very excited that we are able to share with you today resources from London Health Sciences Center, Sunnybrook, and Trillium Health Partners. They all generously agreed to share their recently updated patient education materials with us, so you can download them and make them your own. Yes, I see. Yeah, it's great. Thank you so much for sharing them with us. Okay, so the last overarching strategy in this section on the next page is implement standardized order sets and automated referrals for when hip fracture is suspected. And it reads, use pathways and electronic order sets to embed best practices into routine procedure to expedite hip fracture diagnosis, reduce time to surgery, and reduce complications. And so here you can find 4 examples of order sets from hospitals that have made improvements. And the first 2 of note are available in Word and Excel. So you can download them and edit them for yourself to meet your needs. And again, so happy to be able to include these resources. And it's wonderful to see this kind of collaboration with our partners, and hopefully more of this to come through this COP. Okay, so moving on to the change ideas for surgery within 48 hours. The first change idea is implement care strategies to quickly optimize the patient for surgery. It reads, when a patient with a suspected hip fracture arrives in the emergency department, use a standardized approach to expedite hip fracture diagnosis and preparation for surgery, perform appropriate imaging studies, assess and medically optimize the patient, and provide appropriate management. And so our advisory group has recommended 4 practices specifically to ensure that you embed these in your order sets and care pathways to help optimize the patient for surgery. And so you can see them listed there. And lastly, for hospitals that receive patient transfers for hip fracture surgery, we suggest that you also encourage the smaller hospitals that often partner with you to embed these practices into their care pathway so that the patients are optimized when they arrive at your hospital. Next slide. The next strategy is eliminate barriers to multimodal opioid-sparing pain management use for hip fracture. And it reads, increase the use of multimodal opioid-sparing pain management to address pain and reduce the incidence of complications such as delirium and constipation. Multimodal analgesia, ideally regional nerve blocks, should be administered whenever possible and as early as possible. Regional nerve blocks can be performed by a medical professional of any specialty who has undergone sufficient training. So notably, nerve blocks do not need to be performed by an anesthesiologist. Now, of the change ideas that we've included in this toolkit, this is the one that we know may be the most challenging for hospitals to implement, but we've included it anyway because we do believe that this has tremendous potential to improve outcomes for patients. So it might be a bit of a stretch target. And so in terms of resources, we've included guidance on the effectiveness of regional nerve blocks and how other hospitals have implemented this in their emergency departments. And in future iterations of this toolkit, hopefully, more hospitals will have been working on this particular change idea, and we'll have other resources to include about what worked for them. Next slide. The last idea for surgery within 48 hours is prioritize operating room access based on time since hip fracture. So adopt policies and procedures that assign increasing urgency, based on time elapsed since injury when prioritizing operating room access for hip fracture surgery. So this change strategy is quite straightforward, and we've included Sunnybrook's policy on upgrading priority categories as an example. So this is their strategy, their policy. It reads, book hip fractures as C case upon presentation to emergency department. Upgrade urgency to B case after 24 hours on the C list, but book hip fractures as urgent B directly if greater than 24 hours have passed since the injury. Delayed presentation, hospital transfer, or delayed medical clearance. This policy addresses an important factor that can lead to poorer patient outcomes, namely that a patient initially arrives at one hospital and then has to transfer to a second hospital for the surgery to actually take place, thereby further delaying the fixation. Next slide. Okay, so moving on to weight bearing as tolerated and daily mobilization. The first change strategy is improve adherence to weight bearing as tolerated and daily mobilization guidelines through accountability and education. This change strategy reads, ensure that surgeons and members of the post-operative healthcare team fully implement evidence-based practices on unrestricted weight bearing as tolerated and daily mobilization within 24 hours following hip fracture repair. Encourage team members to view mobilization as a shared responsibility. So in consulting with our advisory group, they highlighted that the importance of weight bearing as tolerated and daily mobilization has been known for a long time. And so our emphasis here is really on making sure that this is always happening. To do this, we suggest that the local surgeon champion undertake clinician audits to identify deviations in this practice and to have discussions to address hesitations that some may have in making this into standard care. And secondly, to encourage all team members to take on mobilization as a shared responsibility. And so we've included some best practices for post-operative rehabilitation from the Rehab Care Alliance and resources on assessing mobility level and making a plan on how to keep older adults active while they're in hospital. Next slide. The next strategy is implement policies that integrate weight bearing as tolerated and daily mobilization into post-hip fracture surgery workflows. And it reads, implement policies or medical directives that integrate weight bearing as tolerated and daily mobilization in a standard post-operative care pathway for patients with hip fracture. So once again, we're looking to make best practices into standard hip fracture care by building it into order sets and pathways. And here you can see these bullets represent 5 strategies that our advisory group thinks your post-op order set should include. And they include things like getting patients up for meals, removing tethers that inhibit mobilization as much as possible, and promoting a mobility-friendly environment. Next slide. And the last strategy is increase patient access to and participation in physiotherapy and occupational therapy. And it reads, ensure that patients begin receiving rehabilitation after 24 hours of hip fracture surgery, including on weekends and holidays, to restore pre-fracture mobility, especially those at highest risk of rapid deconditioning. Optimize patients' ability to participate in physiotherapy and occupational therapy, and do not exclude those living with dementia from receiving rehabilitation. So some ideas to note here include distributing physiotherapy and occupational therapy resources to have coverage 7 days a week. And if that's not possible, prioritizing hip fracture patients who are at the greatest risk of deconditioning due to immobilization for the resources that you do have. And then we also have strategies around optimizing the patient's ability to participate by ensuring they have adequate nutrition to support recovery and aligning analgesics to therapy when appropriate. Okay, and lastly, we have our section on osteoporosis management. So next slide. The first change strategy is adopt and embed the 3I, identify, investigate, and initiate osteoporosis management model of care in hip fracture care pathways. So adopt a 3I model of care for osteoporosis, which is identify osteoporosis risk factors, investigate with blood work to rule out secondary causes, and initiate treatment prior to discharge if clinically appropriate, and embed the model of care in standard operating procedures to prevent secondary fracture, reduce mortality, and improve medication adherence rates. So here we include evidence on how 3I programs, such as the Fracture Liaison Service, is associated with lower subsequent fragility, fracture, and risk and mortality. And of note, Fracture Liaison Service is an example of a 3I model, but you don't have to have a full Fracture Liaison Service to adopt a 3I model of care. So then we have several resources that describe 3I models of care, and we suggest 5 strategies that our advisory group recommended including in your order set to improve osteoporosis assessment and management. And last slide, this change strategy, the last change strategy for osteoporosis management is modify existing workflows to improve osteoporosis therapy initiation in hospital. And it reads, embed practices and procedures in pre-existing or predetermined workflows to increase the likelihood of patients with hip fracture beginning and continuing osteoporosis therapy. And key ideas included here include administering the first dose of osteoporosis medication before the patient is discharged and expanding prescribing authority to interprofessional team members. And to that end, we include an example of a medical directive for pharmacist-led prescribing for secondary prevention of osteoporotic fractures from Sunnybrook. And lastly, we recommend a written transition plan to share with the patient's primary care clinicians. And London Health Sciences Centre has generously shared 2 examples of the templates that they use for transition communications, and these are in Word, so you can download them and make them your own. The family doctor discharge osteoporosis summary, and also the long-term care osteoporosis discharge recommendations. And the next slide, that brings us to the end of our of the toolkit. Now, as we said earlier, the Health Quality Ontario website is down, unfortunately, this morning. And so we had hoped to be able to show you how to navigate to the hip fracture toolkit, but I guess I'll just describe it for you. So this resource is housed on our legacy website, Health Quality Ontario, but you can Google hip fracture quality standard and then click on Health Quality Ontario to get there directly. And in that landing page with our many resources for hip fracture quality standard, under the Getting Started resource, you will see a link to the hip fracture toolkit. And we will share these resources with you in a follow-up email too, so that you can have that. Okay, so next slide. We just want to take a moment now that we've had a chance to show you the toolkit. I wanted to say one more thing. I'm sorry. About the toolkit. So we covered many different strategies in the toolkit, and I just want to reiterate that our intention in producing this toolkit was to recommend the strategies that our advisory group have seen work in their experience, and also to provide you with many different options and opportunities to improve care, so that hopefully every hospital can find a few strategies in there that are relevant and achievable for your context. Okay, so now that you've had a chance to see it, we would like to invite you to complete a 1-minute survey so that we can hear from you as to what you see as being a top priority for implementation for your organization among the different change ideas that we shared. So we'll invite you to open up this, use the QR code, or I believe we're sticking a link in the chat to open this survey and take a moment to complete that. And with that, I will pass it over to Carol for the last part of our presentation.
Carol, you're just on mute.
Okay. Oh, sorry about that. Are we okay to go ahead with people? I guess people can continue to complete the survey. Next slide, we're going to review the ECHO session calendar related to implementation. And thank you for taking the time to complete the survey. It's going to help us finalize planning of our proposed learning calendar for QI sessions within ECHO. And we wanted to update you on plans for the following year. We intend to introduce a QI-focused ECHO session once every quarter, starting in April 2026, so in the new year. The intent is to focus on the priority quality statements and change ideas, in addition to real-life examples that reflect opportunities for learning and collaboration. As you can see, our first session will be in April, which will focus on fast-track pathways for timely hip fracture care and surgery. And we've just confirmed our spotlight presentation to be University Health Network's Code HIP project. Then in June, we'll focus on improving outcomes through early mobility and weight bearing is tolerated. In October, we hope to discuss using order sets to standardize hip fracture management. And then in January 2027, we'll focus on strengthening hip fracture care through osteoporosis management. To give more opportunity to focus on real case studies and examples rather than theory, these QI sessions will be structured a bit differently, with a short introduction followed by a 1-hour QI spotlight case presentation. And this will include an in-depth real-life example with facilitated discussion. We're hoping these sessions will be valuable and insightful and look forward to your continued feedback. So moving on to the next slide. So what can your hospital do to get involved in Ontario Health's 3-year strategy to improve hip fracture care? And we've highlighted a summary of tasks and action items to get started. First, establish an implementation team. Identify local quality improvement and data lead or clinical champion. Engage leadership and secure buy-in, and build a committed team to begin reviewing current practices. Secondly, use the hip fracture e-report to access your local data, assess performance, and build a case for change. And thirdly, use provincial supports to guide your quality improvement journey. Select strategies, tools, or resources from the toolkit and adapt them to your local setting. You can add the hip fracture indicator to the 2026 QIP submission. If eligible, and if your hospital participates in ONSQUIN and NISQIP, you can have an additional or enhanced data collection and QI coaching available through ONSQUIN. And again, attending the ECHO community practice QI sessions. And as we mentioned earlier, we'll follow up with all of the links we've shared today. The next steps we have highlighted in a 1-pager, and we'll also be sharing that through Jenny, and we can have her posted on the ECHO website as well. So moving on, we'll thank you for your time and allowing us to share the 3-year strategy and the hip fracture care implementation toolkit, and we'll open up for a few questions before we go on to the next section. On this slide, there's a few email contacts. If you have any specific questions, feel free to reach out to either Corrine, a manager in our quality standards program, or through Jenny, and their emails are listed on this slide. Jenny, if there aren't any questions now, we can also leave it till the end if you want to go ahead straight into the E2P presentation.
Sure, I think that sounds good. If there's no burning questions right now, let's move on to this MMV2.
Perfect.
Hi, everyone. Thanks for having me. And also thank you to Dana and team for presenting a sneak peek of the toolkit. It's very exciting work, and I know so much consultation and work went into it, so it's great to see it live. My name is Sam Lee, probably many of you whom I haven't met before, and I'm a manager of digital health at North York General. I actually used to work at Kingston General Hospital as an RN on the orthopedic unit, and then moved to North York Gen to work in the Emerge. So I'm hoping to bring my point of view from my nursing background and then also experience with health information system implementations in my digital health role to what I'm about to share with you today. I'll start by saying that I think it is so valuable to have practical, action-oriented strategies for organizations to implement quality standards. So again, really appreciated the presentation that we just heard. For today's session, I'm here to share with you about the Evidence to Practice program and its connection with the hip fracture quality standard as a digital lever. So if I were to sum it up all into one sentence, Evidence to Practice, or E2P, is a provincial program that translates quality standards into digital change ideas. North York General's role specifically is to work with interested hospitals to leverage functionalities within health information systems. So what does that mean? That's really looking at things like order sets and documentation forms to make it as seamless as possible for clinicians to follow the quality standard. You will hear more about different quality standards we have helped organizations implement and the opportunity to become an E2P pilot hospital for hip fracture implementation later on. But do keep this in mind as we progress through the session. What we really want to know today is if the hip fracture digital change ideas that we are sharing are resonating with your organization's current state. And if you would be interested in learning more about E2P and work with an external partner like us to guide you through implementations of these digital change ideas from beginning to end. Next slide. So reiterating what Carol said earlier, there are multiple provincial supports and levers across the province that can help your organization implement the quality standard, such as the implementation toolkit that we just heard about, and then also the Evidence to Practice program. Next slide, please. E2P specifically can be a key support in accelerating change within your organization. What we do is provide resources and tools to support digital implementation in your organization, again, taking you through the implementation journey from beginning to end. If we just move to the next slide, I'm going to clearly delineate what our goal here is today. So in today's session, I will be sharing with you some digital change ideas or digital enablers that nicely align with the hip fracture implementation toolkit and quality standard. And I also want to gauge if there's any interest from you or your organizations to become an Evidence to Practice pilot site, and then understand what your organizational priorities might be. Next slide. So before I share our list of digital change ideas, I thought it would be important to show how we got to this prioritized list. Our starting point was the hip fracture quality standards, and back then it was still a draft of the hip fracture toolkit. We looked at these documents and we started identifying digital enablers that would support the implementation of the quality statements. This initial list was then shared with subject matter experts through October and November. We had small group and one-on-one consultations with a number of you, and the conversation was genuinely insightful. We learned a lot about the value, the practicality, and even the scalability of some of the digital change ideas related to the quality standard. And now what we've done is we've synthesized the feedback, and we are presenting back to you the digital change ideas related to hip fracture quality standard implementation. Next slide. The quality statements that we will focus on are based on the expert consultations we've had, and these are areas where we see digital opportunity to implement the quality standard. We'll be looking at 5 key quality statements: weight bearing as tolerated, daily mobilization, screening for and managing delirium, post-op management, and osteoporosis or bone health management. So you'll see quite a lot of alignment with the hip fracture implementation toolkit. So let's get into it. Next slide. To embed weight bearing as tolerated into post-op surgical workflows digitally, which again, we're seeing as a prioritized change idea in the hip fracture implementation toolkit. The use of standardized order sets will be key, and Dana did talk about this. Before I get further, all these digital change ideas that I share, including this one, do need to be coupled with provider and nursing education and also reporting to understand adherence. Most of the time, we are finding that it's not overly difficult to make order set changes or implement new documentation forms or fields in Oracle, Epic, or Meditech, but the real difficulty or value is really spending time explaining the why behind doing something, and then also understanding the barriers in organizations for, let's say, nurses to carry out certain orders. And this work, I think, is what will help us ensure that the standard of care is always being followed or consistently being followed. So coupled with provider and nursing education, what we will do is work with E2P hospitals to review your order sets and ensure that weight bearing is tolerated within 24 hours is a standing order in your post-op order sets. Next slide. In this order set review, we will also work with you to ensure that daily mobilization once daily is a standardized default order. To accurately evaluate that mobilization is occurring, we also propose that organizations review the way that clinicians are documenting mobilization. So we should be ensuring that there is a discrete field to check off transfers and ambulation that's occurring each day. And we need to use that information to evaluate mobilization across hip fracture patients in your organization. There may also be multiple members of the interdisciplinary team who are working together to mobilize patients, PT, nursing, etc. So ensuring that each of these members has a standard place to document mobilization, and then also working with you to make sure that they're retrievable by decision support or reporting experts is part of the work that E2P does with organizations. Next slide. We know that people with hip fracture are at a higher risk for delirium, so we will also work with E2P pilot hospitals to implement a digital delirium screening tool for all hip fracture patients. We've been consulting some amazing people from the Delirium Aware Safer Healthcare Committee, and they have a whole repository on validated screening tools and pathways that hospitals across Ontario have already implemented. So there are a plethora of contacts that the E2P team can connect your organization with. When scoping out this digital change idea, we heard that delirium screening can be a resource burden, and having screening done within 8 hours of a patient's arrival when they are likely still in emerge is probably not feasible to always accomplish. So we've extended the time frame to have someone screened within 24 hours as our evaluation metric. Again, this was based on feedback from geriatricians and ED clinicians. And we also heard that with delirium, sometimes the way that you do screening or ask the question can affect the results, whether someone screens positive or not. So this will be one of those change ideas. We're working with extremely strong clinical champions to implement this well will be especially important. Next slide. There are standard non-pharmacological interventions that can be implemented to prevent delirium, and these should be a standard part of a nursing shift. So we will work with organizations to implement practical documentation checklists that can be used Q-shift, and these checklists can be used for anyone who is at risk for delirium, example, hip fracture over 65, before they've even been screened positive. If someone does screen positive, the same non-pharmacological interventions or checklists can be used to then manage delirium. Our work with organizations will really involve looking at implementing digital prevention and management bundles, and also working with you to find creative ways to promote implementing these non-pharm interventions in your organization. During our scoping consultations, we spoke with some reps from Quinte Healthcare, and they're doing so much work to promote more thoughtfulness and awareness surrounding implementing non-pharm interventions to prevent and manage delirium in their organization. But what they've done is they have a scheduled series of huddles, and each week they focus on a different non-pharmacologic intervention. And there's prompts for leaders to genuinely understand barriers for achieving something such as mobilizing your patient daily. And they're also providing their staff with practical checklists and to-dos for each intervention. So things like drafting up a huddle schedule for education topics is something that the E2P team can support your organization with doing. It's not exactly digital, but it is change management related to a digital change idea. And we can also share information on what other organizations such as Quinte is doing and offer suggestions tailored to your organization's context. Next slide. Now, if someone does screen positive for delirium, there should be an assessment from a provider to identify the root cause of delirium. E2P will basically help implement a new order set or review an existing order set that can have standard order sentences that identify the root cause of delirium. Just like hip fracture order sets, there are a few examples from different hospitals that have already done this that we can 100% leverage, so we're not reinventing the wheel. Next slide. In the hip fracture post-op order set, E2P sites should also have orders related to VTE prophylaxis, instructions to ensure that indwelling catheters are removed, and that indwelling catheters are just not even an option if a patient is retaining. As one of the steps to implement an orthogeriatric model of care, we also propose that there's an automatic or pre-selected consult to a service with geriatric expertise in your hip fracture order set. This digital change idea is truly more than just adding an order in the order set. It will require collaboration between geriatric specialists and orthopedic surgeons to iron out the roles and responsibilities of MRP versus consulting, who should be paged first for which issues, etc. We predict that this pathway could look different depending on the organization, but I think the main idea or the gist we're getting at here is that people with hip fractures should be managed by both an orthopedic surgeon and a clinician with geriatric expertise. Co-led by our Chief of General Internal Medicine and Orthopedic Surgery, it took Northrop General about 4 months end to end to implement this model of care. So sharing that it is definitely feasible and practical work that can happen in your organization. Next slide. In alignment with the hip fracture implementation toolkit, we also want to prioritize measuring the percentage of people with hip fracture who are started on osteoporosis medication while in hospital. So these medications can be added to the discharge section of a post-op order set, and it should be implemented with strong physician champions from each hospital. We heard in our consultations that there could be a few barriers to implementing this, such as maybe that medication isn't in hospital formulary. There might even be some discomfort in providing or in prescribing osteoporosis medications. There's enough evidence to say that this is the right thing to do. And we saw some amazing resources in the hip fracture implementation toolkit that Dana and team just shared. So E2P will be referencing this toolkit for evidence on the whys and the how-tos for starting these medications for those who are not contraindicated in hospital. Next slide. So what I've just shared is the list of digital change ideas that E2P pilot sites will implement. And our next step is to really start recruiting hospitals who are interested in starting the implementation of these digital change ideas related to hip fracture care. V2 is our senior program manager for E2P on the call, and he's going to take over and just share more about what it means to be an E2P pilot site and how we can be value add to your organization's quality standard implementation. So I'll pass it over to V2 before we take questions. Go ahead, V2.
Okay, thank you so much, Sam. We can go to the next slide. So just to take a step back, the Evidence of Practice Ontario program is a program that we run alongside Ontario Health. Northrop General Hospital is one of the lead organizations alongside the Center for Effective Practice and Amplify Care. We work closely with Ontario Health to try to enable this mission where we translate quality standards and clinical practice guidelines directly into tools that a hospital clinician will use. And this includes their information systems such as Epic, Meditech, or Oracle. And we've done this for since about 2022 so far with a variety of different use cases. And we've had about 21 different hospitals come on board to be able to actually do these level of implementations. Each hospital is unique and different in their own ways in terms of their digital maturity, the resources that they have, the clinicians that they have on board. But we've been able to work with them to be able to make sure that those use cases are of value directly to them. And we've had about 4 use cases so far with sickle cell disease, diabetes, anxiety and depression, and heart failure. And then now our latest use cases are hip fracture delirium. So we hope to sort of progress and scale this ultimately for the point of if a patient comes into any hospital within Ontario for hip fracture delirium care, they're receiving good quality care. And our goal is to basically support hospitals in being able to enable that. On to the next slide. So then with this, like through the scope that Sam has just walked through in terms of the potential digital change ideas as well as the metrics we're hoping to collect, we do want to support hospitals in doing this. We recognize that change at each individual hospital level takes work and takes effort. So as part of the program, we're hoping to provide hospital sites with specific implementation support. This could be project managers who can help guide the implementation from start to finish to support their resources. provide and support that change management that hospitals will typically do at the local level to make sure their clinicians have a good understanding of the different use cases involved, as well as what the sort of changes are and how they can better adopt it. And then support them in building artifacts, whether it be either change management material, supporting the documentation of a new workflow. We try to help the hospital and be as flexible as possible to ensure that they can make these changes and make these changes stick. And as part of this, we recognize that hospitals have to provide resources as well. You might have to involve your clinical informatics team. You might have to get your clinical team members on board. You have to get your leadership engaged to make sure that they can actually do this work. So we do provide funding to the hospital sites to support those internal resources. This could be for clinical informatics time to make changes to the hospital information system, such as Oracle, Epic, or Meditech. It could be for clinicians to be able to make sure that they can dedicate time to looking at their workflows and making adjustments rather than being at the side of their desk, or even to their decision support teams to make sure you have the appropriate data to actually drive forward that implementation use case. Finally, although we have a high level scope and we have that scope that Sam has identified for both hip fracture, per hip fracture, we do look to adjust our scope where possible and where necessary for the hospital. Ultimately, we do want to report on the same sort of metrics and have similar levels of change. We recognize each hospital can be different in terms of how their workflow shapes out to be. So we work closely with the hospital to make sure that any of the changes that we add are not necessarily reinventing the wheel. They're adding value. They're addressing gaps specifically at that level and support them directly. On to the next slide. So we are recruiting for for next fiscal year, which starts in April for 26-27. So just to plug before I pass it back to Sam to be able to guide us through a discussion. If you are interested in becoming an E2P partner site, or you have clinical interest in the hip fracture care or the delirium use case or anything that you heard about today, please feel free to email myself or Sam. Our emails are on the screen. Or if you forget our emails because our names are somewhat long, you can also go to CEP's website, so cep.health/E2P/signup, and you can express your interest there. One of our team members will look at it. We'll look to have a meeting with you just to better understand how we can support your hospital and then how we can better essentially implement the hip fracture quality standards at your hospital and give that level of support that may not necessarily be there without it. But thanks for that. I'll pass it back to Sam to do discussion.
Thanks, V2. So in the next few minutes, we'll say Amanda, also part of the E2P team, is going to paste a link in the chat to a 1-minute survey that we ask everyone to fill out. But we should be seeing 91 responses because there's 91 people on the call. And while you're all opening up the link and maybe you're thinking or you're starting to type, we also invite any brave souls to raise their hand and to share their thoughts in real time. It's really important to us that our scope of implementation is feasible, practical, and frankly valuable to hospitals. So the first question that we're going to pose to the group for any sort of input is, with the digital change ideas that I just shared, what barriers do you foresee with implementing some of them or any of them in your organization? Most of them were order set related changes, such as making sure that weight bearing as tolerated, daily mobilization, VTE prophylaxis, indwelling catheters are removed, etc. And then there was also implementing an orthogeriatric model of care and then starting patients on osteoporosis medications before leaving hospital. And then, of course, the delirium screening, prevention, and management bundle. No worries if people maybe are still processing and perhaps also need to take it back to others in their organizations before answering. But Amanda has the link in the chat. We really do look forward to seeing your offline feedback. And I think I saw a hand just for 1 second and then it disappeared. Did I miss it?
Hi, Samantha. It's me, Catherine Ellett.
Oh, hi, Catherine.
So thank you all fantastic work. So the link to the delirium campaign and piece and the how we would measure daily mobilization has been something we've been looking at for a few years. So I think the challenge there is, for patients non-ambulatory, how do you define that and then document that? So that's kind of the flag and the one change idea that we're really passionate about, but it's definitely a tough nut. But thanks for slide 38 was great.
What difficulties are you seeing in your organization specifically?
Well, currently we don't have a spot to put aside from ADLs, which has been challenging to pull out. So, building a place, and then of course, just what is general nursing documentation burden, defining mobilization, is it up to chair for those non-ambulatory? I know Jenny Thane and I had a fantastic presentation about sort of arm movement and bed dancing for the geriatric population, but things like that.
Yeah, when we start really ironing out those technical specifications for measurements, it sounds like Jenny, Catherine may be reaching out to you to review those technical specs as well to make sure that we're defining things in a way that is clinically accurate and makes sense.
I'll just say that Catherine and I would be super happy to work with you guys. I've put our information there, but then I think I've asked this question because it came from Catherine as well about if an organization is doing both hip fracture and DASH, can we work with you on both of those initiatives at the same time?
Yeah, we're hopeful that we can make something work. We actually have some discussions with our OH partners coming up in the next couple of weeks to really iron out what that means. So I have both you and Catherine's contact. 100% will be reaching back out to you once we've ironed out the details and can share a concrete plan with you.
Samantha, as well, maybe we'll connect. We've been looking a little bit at the weight bearing as tolerated mobilization. Bone and Joint Canada did a few pilot sites using special projects fields. So we have some examples of some tech specs from there we can share with you. And we've been talking to one organization just to see like how they would go about coding and building it into their EMR. So maybe we can chat as well.
100%. Send them my way, Carol.
Corinne, I don't know if you had anything else to add to that.
Nothing else to add, only that, we are equally interested as Ontario Health in figuring out how we incorporate additional measures into our e-report. So all of those 5 priority quality standards statement areas that we presented at the beginning, we want to figure out what is feasible to measure. Obviously, we have to be really mindful of effort that requires on a hospital's part. So we're trying to proceed responsibly, but yes, very interested in what is possible to measure with minimal effort in terms of weight bearing as tolerated, daily mobilization, as well as obviously the osteoporosis management through medications. So we'll definitely be coming back to this group to provide updates as we move the data measurement strategy forward.
Sherry, then you've got a question?
Yes, just to step back a bit with respect to the measurement issue. One of the quality standards is preventing readmissions, and the reason everyone is there with a hip fracture is a fall. And I know the fall and frailty group is hopefully getting up and running soon. But I think in the interim, before we kind of see recommendations out of that group, we really need to be measuring falls, because the people leaving hospital post hip fracture will be at higher risk of falls, not lower. And just some of the data I've seen through our hospital, the 30-day ER readmission for falls, just all comers, is high. So I would like to see us measuring falls presentations in the eMERGE as a standard I think it crosses a number of the health quality standards, to be honest.
Sherry Lynn, just want to make sure I've documented it correctly. So you're proposing that we should be measuring, I guess, like number or rate of people that were admitted for hip fracture, discharged, and then readmitted back because they fell at home.
100%. Yeah.
Got it. Thank you.
I would say fell anywhere, because some of these patients do go to rehabilitation transitional care units, and that would also be included, not just patients who go home.
Mm-hmm. Thank you. Any other questions or comments? Nicole.
Hi. So in the Northeast, we have the RGP within our structure has clinical implementation specialists. And so these are for sub-regional roles that work directly with organizations around implementation of senior-friendly care practices. And so, right now we have done geriatric care pathway events. We have identified sort of some opportunities amongst the care pathway of older adults, and sort of thinking, kind of hearing your presentation, I think there's an opportunity for collaboration, but I worry about that direct link to organizations and then our direct link to organizations, and there just being already a lot of siloed approaches to implementation. And just wondering what your thoughts would be around collaboration with an RGP to then support with a regional or sub-regional support system for those organizations.
Yeah, such good points. A2, do you want to take this one?
Yeah. I think the ETP team and I'm assuming OH as well, like we're open to that level of collaboration. We don't, again, like we don't want to actually reintroduce new work or cause confusion in terms of too many messages happening from multiple different organizations. Transparently, I'm less informed about the RGP work, but like happy to connect Nicole. I'll make a note to send you an email after this, so we can connect and see how we can better align the two programs and the implementations. It'll be good to know which hospitals you're also implementing with and see how we can take a coordinated approach there as well, if it's possible.
Maybe I can just add to that, Nicole. Thank you for calling out the opportunity to break down some of the silos. We definitely see that obviously between the falls, frailty, and the hip fracture work, there's lots of work that needs to be thought through in an integrated way. In terms of RGP role, I know that Kelly Kay had presented also to the RGPs. I want to say, I think early, maybe it was late last week. And we're actually going to be speaking with her early next week. And so would love to continue to think about how the pieces fit together so that we're all, rowing in the same direction in an integrated and coordinated way. So completely appreciate that comment.
Yeah, because I think like right now we're talking hip fracture, but for me, when we think about the work, it's all older adult care. So for example, one hospital in Sudbury wants to implement MOVE. And so we're working on cardiology, but eventually we'll spread throughout the organization, right? So it's like, what does this look like for all older adults with frailty, falls, whether they have a fragility fracture or not, and thinking about spread throughout organizations. And so that's more of our lens. And not only focus on hip fractures, but so thinking about those opportunities, and these tools are amazing, and how can we actually use them for all older adults and within acute care?
Yeah, absolutely. And even, if we look sort of downstream, we know that if we don't do the stuff well upstream in terms of managing falls, managing frailty, preventing hip fractures, then we end up with more people going into hospital, more ALC, which is a really high priority for hospitals right now and for Ontario Health. So I love that you're calling this out. I think we're going to have more conversations. Happy to be part of a follow-up conversation with you two. But and Kelly, if it makes sense, I don't have an update on how that conversation went with the RGPs last week. So if there's a good opportunity to sort of connect the dots, I would love to do that.
Not seeing any more hands. So with that, I think I'll pass it back to Jenny. And just wanted to say thank you everyone for tuning in. And it's extremely exciting to see all the pieces coming together. And I like Kareen's analogy. The exciting work will also be making sure that we are rowing in the same direction. So yeah, really looking forward to being a part of this change. Back over to you, Jenny.
Great, thanks, Sam. Thank you to everybody from the Ontario Health team and the ETP team it was great to have walked through the entire toolkit. I know I've seen it before, but it's actually nice to have kind of go through it step by step, and also to understand more about the E2P program and opportunities that are upcoming as well. I do just want to mention that we have popped the feedback link into the chat. So if anybody has some time, I would really appreciate if you provide any feedback on either the ECHO program or the presentation that we've had today. That was really helpful for us as we continue to plan ongoing activities into the new year. And as Marcia also highlighted in her comment, just a reminder that we do have the YouTube channel that's available now, and it's on, the link is on the landing page for the ECHO Orthogeriatrics, and we will be uploading this presentation there within the next couple of days. So if there's anything that you needed to go back and watch, or if you want to share it with any of your colleagues, please feel free to do that. And with that, I think we can give you back 22 minutes of your afternoon. I want to wish everybody a very Merry Christmas. Have a great New Year. I hope that you get some time off and downtime over the holidays. We will not be having any sessions over Christmas, and we will see you again in the new year. Have a great afternoon, everybody. Bye.